Welcome back. Let's discuss reflux. And let me lead by saying this. My level of confidence that you can resolve your reflux if you follow these steps is extremely high. In the clinic, we see this quite frequently. We'll cover 3 cases later that sort of exemplify the success we've had, breaking down reflux to 6 root causes. And this is something that can be quite unsettling. In fact, this is going back maybe 5 years, a little over. Mona, her reflux was so severe, she went to the ER because of the unsettling symptoms, which is why I'm eager to share with you this 6-component model that I think will help you resolve your reflux. And I'm defining resolve by not having to shrink down your diet to nearly nothing, but to be able to use diet amongst other tools so as to heal the esophagus, the lower esophageal sphincter, and other underlying causes that we'll cover momentarily, and then be able to tolerate a wider variety of foods. So we'll go over the 6 causes, the corresponding treatments, and then perhaps most importantly, how you organize this into a step-by-step protocol that's personalized, because not all reflux has the same underlying causes. It's not complicated, but we need to personalize this to the individual. So let's get started. Just a few points of preamble. You're not alone. Reflux, or LPR, whether it's active or silent, impacts roughly 20 to 30% of the population. Classical GERD involves heartburn, chest pain, this feeling of regurgitation, and nausea. There's also silent reflux, or LPR, and this is where people may have hoarseness, chronic throat clearing, a feeling like something is stuck in the throat, chronic coughing, or difficulty swallowing. And there are, as you probably already know, long-term complications associated with chronic reflux, or LPR. The damage to the lining of the throat and the esophagus and the vocal cords can lead to things like airway issues, strictures, or essentially scabbing that can occlude the airway. And even when the damage becomes chronic, can lead to Barrett's esophagitis, and that can eventually lead to esophageal cancer. Now, all that being said, again, there's a lot we can do, but I just want to lead with a few of these points. In terms of what might be the common root issue, not necessarily the cause, but the root issue for all of these cases is a malfunction in what's known as the lower esophageal sphincter, or the LES. And it opens to allow food into the stomach, and then it should close and not allow the acidic contents of the stomach to reflux upward. But if this sphincter is faulty, you have reflux. And there's one data point I wanted to lead with here. Taking a step back, it's incorrect and I think a bit antiquated to say that all reflux is due to having acid levels that are too high. In fact, roughly 50% of patients will not obtain relief, some are even flared, by using acid-suppressing medication. This study looked at GERD patients versus healthy controls, and they found that both groups had the same level of acid produced in the stomach. But the GERD patients had 2.6 times more acid in the esophagus, coming back to that faulty lower esophageal sphincter really being the thing that we want to target. And just quoting from these researchers, this confirms that it is not the volume of gastric or stomach acid per se, but rather the distribution of secretions, so coming up into the throat, that leads to prolonged exposure of the esophagus to gastric secretions like acid. And by the way, I would welcome you to comment. I enjoy going back and forth with you guys there. Like and subscribe so this video can reach and help more people. So now let's go to this 6-component model. The first factor, dietary. Now, there's a few trigger foods that we should cover. You've probably heard of, but let's just go over these really quickly. Again, with the agreement that all of these foods, if we heal the lining of the esophagus and correct function of the lower esophageal sphincter, you should be able to then consume. But in the short term, like I've said on the podcast many times in the past, think of diet like a rehab plan for having had injured your low back. Sure, you wouldn't be able to engage in certain exercises and activities for a month or two or so, but with the appropriate avoidance of activities and rehab plan, you can then go back to these activities. So the trigger foods to be avoided in the short term: coffee, caffeine, alcohol, chocolates, mint, spicy food, citrus fruits, and also overeating just categorically. It's not to say you have to get these foods down to absolute zero, but you want to try and mitigate. Okay, so those are some of the common, probably you already know of, trigger foods. There's another layer to this that gets more to the underlying dietary causes. Zooming out a little bit, my observation over the past 10 plus years has been in the gut, people tend to have one of two types of dysfunction or imbalance in their flora, in the healthy bacteria and fungus. In fact, that's exactly how the imbalances skew toward bacterial overgrowth. On the one hand, you may have heard of SIBO, small intestinal bacterial overgrowth, or fungal overgrowth, including but not limited to Candida, on the other. And this has implications for you cueing in on what dietary changes to make. But let me give you a few of the data points that sort of support this model. Looking at bacterial overgrowth, what's interesting here, a 2022 randomized control trial took 8 patients with GERD and either put them or administered to them a high FODMAP, so this is going to be high in foods that feed bacteria, or the other group got a low FODMAP meal. So these are foods that will not feed bacteria. The high FODMAP bacterial feeding meal led to more relaxation of that lower esophageal sphincter, more gas production as hydrogen and methane. This is probably part of why the sphincter opens in some people. Too much bacteria. Those bacteria, when they metabolize food, make gas. That gas produces pressure. That pressure pushes open the lower esophageal sphincter. And then correspondingly, as you would expect, the individuals who consumed the high FODMAP or the high bacterial feeding meal had more reflux, more bloating, more belching, and more fullness. So this just exemplifies that in some people, part of why that lower esophageal sphincter opens is they have too much bacteria, they're making too much gas, and there's modifications we can do to correct that and not need to follow that lower FODMAP diet in the long term. Again, all of this will sort of organize into a protocol for you, just trying to lay some of the underlying causal groundwork for you first. So I said bacterial overgrowth on the one hand, fungal overgrowth on the other. This enters a 2022 randomized control trial. 98 patients with reflux were given either a high simple sugar and carbohydrate diet versus a low sugar and carb diet. As you would probably expect, the high sugar diet worsened GERD, led to more acid in the esophagus, and was probably provoked by some of the underlying foods: white bread, white rice, pudding, jelly, apple butter, raisins, and bananas. Now, I'm not saying these foods are always bad, but coming back to that rehab analogy, if you are a gut type that is fungal overgrowth, then avoiding sugars and higher carbohydrate eating is going to be corrected for you. And if you're someone who has a bacterial overgrowth, avoiding high FODMAPs will be helpful for you. Again, all of this will be sorted out in the protocol, but just trying to walk you through what's going on underneath the surface. So that's component 1, dietary changes. Component 2 is inflammation. Now, inflammation leads to increased nitric oxide. You've probably heard of nitric oxide, which leads to vasodilation or blood flow. It's in a lot of supplements that are pre-workout are precursors to nitric oxide to get that blood flow. However, nitric oxide isn't always good, and in conditions of excess of inflammation can lead to high levels of nitric oxide. And this actually leads to the lower esophageal sphincter to open. Numerous studies have documented this. And this is probably why we see other inflammatory conditions associated with reflux, like inflammatory bowel disease, irritable bowel syndrome, and rheumatoid arthritis. So addressing inflammation, very important. And pretty much every recommendation we're going to walk through will reduce inflammation. But let me give you one very important case in point study showing that anti-inflammatory interventions can be very powerful. You've probably heard of curcumin, this anti-inflammatory spice. 2023 randomized control trial compared the blockbuster acid-lowering medication omeprazole versus curcumin at 2 grams per day for 1 month in duration. Quoting the researchers here, curcumin and omeprazole had comparable efficacy for functional dyspepsia. That's sort of a catch-all term that would include fullness, GERD, indigestion. That's the functional dyspepsia. So pretty remarkable that curcumin, which has other side benefits like reducing joint pain, is as effective as omeprazole, and it won't have, of course, the long-term complications that acid suppression with omeprazole will. One quick aside, if you are using a lot of nitric oxide supplements like L-arginine, L-citrulline, beetroot powder, many of these are, again, in pre-workouts, short-term avoidance may help calm down the reflux, and then you can bring these back into your diet or into your supplement plan. Coming over to component 3, we've hinted at this already, but the microbiome. And there's a few ways, again, this can skew bacterial overgrowth, fungal overgrowth, but I wanted to tie together 1 or 2 more data points as to how underlying imbalances in the microbiome, in the good commensal bacteria and fungus, can be leading to problems with that lower esophageal sphincter. One study found, in fact, 2 studies had a similar setup and a similar finding, so I'll just summarize both. They looked at patients with either silent reflux in the one study as LPR, or your classical GERD in the other study, and they found anywhere between 40 to 46% of patients with either LPR or GERD had SIBO, small intestinal bacterial overgrowth. This correlated with worse LPR or GERD symptoms and more damage to the esophagus. This led one of the research groups to comment as follows: we postulate that SIBO may be a contributory factor to refractory, meaning it's not responding, reflux symptoms due to bacterial fermentation in the small bowel. Bacterial fermentation is just essentially too much bacteria, too much gas, and then remember that gas seems to be what pushes open that lower esophageal sphincter. If you've done some research on this, you may have come across Helicobacter pylori or H. pylori, this bacteria that resides in the stomach and potentially in the small intestine. There's some correlation, but it's not super straightforward. So let me clarify some of the confusion here and help give you kind of the path forward. Having H. pylori actually reduces risk of GERD, but treatment of H. pylori increases the risk of GERD. Why is this? Well, H. pylori, that bacteria, will negatively affect the parietal cells in the lining of the stomach that make acid. So you will actually have acid suppression secondary to the bacteria. So even if stuff does reflux upward, it's less acidic. And this is partially the merit for the acid suppressing medications. They're not really solving the problem, but they're mitigating the symptoms. So H. pylori suppresses acid in most people, but then when you treat the H. pylori, there's no more acid suppression, there's a normalization of acid levels, and if at the same time that lower esophageal sphincter is faulty and things are refluxing upward, you will see an exacerbation of reflux. So what does this mean? Well, it just means that if you're tested positive for H. pylori, it's usually a good idea to treat. There's a little bit of gray here, but it's usually a good idea to treat that, but you may have to do some work, as we're talking through with this protocol, after treatment of the H. pylori to make sure that your sphincter works correctly now that you have normal acid. Another very important component here is the nervous system. There's 2 arms of the nervous system. There is the sympathetic, fight or flight, and there is the parasympathetic, rest and digest. So if people are overly stressed, therefore overly sympathetic, this can cause issues with reflux. One observational study of over 12,000 individuals found that people with moderate to high stress levels had a 2 times greater risk of GERD. Quoting, individuals exposed to higher levels of stress are more likely to have GERD symptoms. Therefore, stress reduction should be an important part of GERD symptom management. And I want to tie in the vagus nerve. So sympathetic is fight or flight, parasympathetic is rest and digest, and it's really chiefly the vagus nerve that innervates this parasympathetic action. So we can look at the vagus nerve function as a way of understanding if people are not parasympathetic enough, or said another way, if they're overly stressed, and if that correlates with GERD. One study looked at GERD patients, and they found that the heart rate variability when measured over 24 hours, heart rate variability, or HRV, is a proxy for stress levels. The higher your heart rate variability, the healthier your stress response. The lower it is, the worse. So quoting from these researchers, patients with GERD have distortion of sympathetic and parasympathetic components of the autonomic nervous system. We'll give you a few different techniques that are quite easy that will help push your body more toward the parasympathetic or vagal arm. And this is important for all the reasons we outlined, but also tying in the concept of inflammation. The vagus nerve secretes acetylcholine, and acetylcholine is strongly anti-inflammatory. It's going to affect mast cells, macrophages, T cells, and dendritic cells, all immune cells that will dictate inflammation, including an inflammatory response to foods. So if we get this right, we should see reduced symptoms and also better dietary tolerance. And there are some data, the one data point here that I think is pretty exciting, looking at vagal nerve stimulating devices. So these can be as simple as earphones you wear for 20 minutes per day that decrease inflammatory markers in inflammatory bowel disease, really showcasing that whatever the intervention, if we get more parasympathetic, we will have a reduction of inflammation. The fifth factor are a few physical factors. One you may have heard of or maybe even been screened for is hiatal hernia. This is where the lower esophageal sphincter protrudes over sort of its holding point in the diaphragm. There is something to be said here in terms of the greater the level that the lower esophageal sphincter has herniated upward, the higher the likelihood of GERD. If it's a small hernia, less than 1 centimeter, one study found a 27% correlation with GERD. If it was a moderate, between 1 to 3 centimeters, there was a 38% correlation with GERD. And if there was a large, or over 3 centimeters, there was a 54% correlation with GERD. There is merit to the corrective surgeries. Although if you're watching this video, you're probably looking for what can be done so as not to need to undergo surgery. And this is everything that we're talking about. Because remember, while having that sphincter in the appropriate location will improve its function, there's also many factors we can use, like reducing SIBO or fungal overgrowth or curcumin, that can help with inflammation, sphincter tone, and therefore may preempt the need for a hiatal hernia corrective surgery. And there's a few other factors that are physical in nature, mainly that increase pressure in the abdomen. Because remember, if there's a lot of pressure, that pressure, kind of like squeezing a balloon, presses up on that lower esophageal sphincter. This is why slumping after eating or laying down after eating are both not good ideas. And also being overweight puts more pressure on the abdomen. So if possible, losing weight can also be helpful. Now, coming to the sixth factor of our list of 6 is low stomach acid. This is actually a somewhat rare cause of reflux. You will see it occasionally. In fact, I'll share what was a pretty remarkable sort of textbook case with Mason from a few years back, where he had a remarkable improvement amongst, a few other interventions, but a real strong response to hydrochloric acid supplementation. And there are risk factors that could indicate you are low in stomach acid. There's really 3 main ones here. If you're over 65 years of age, if you have a diagnosed autoimmune condition, and if there's a history of pernicious or iron anemia, those increase the likelihood to about 50%, maybe a touch less, that you'll have low stomach acid. If you try a stomach acid supplement, then you should see an improvement within a few days to 1 or 2 weeks. So with many things in the GI at least, if it's the right support, you'll see improvements pretty quickly. The one thing I would flag for you is in the clinic, we see so many people who've been on acid for a long time, devoid of any response. That's not the way this should look if you're low in stomach acid. If you're low acid, like Mason's case beautifully portrays, you will see a notable improvement within a few days to a week or so. So now let's put everything together in this corrective protocol. I've broken it down to 2 phases. The first phase, give yourself 1 to 2 months on this. And if it's the right support, if it's the right program, you will see clear benefit. There's a few directions we can go dietarily. The one diet that's going to satisfy all of these criteria is really, in my view, the paleo low FODMAP diet. It's a combination of reducing higher carb and inflammatory foods and reducing high FODMAPs, so integrating low FODMAP. So hence paleo, which is sort of anti-inflammatory and moderate to lower carb. So this will hit inflammation and fungal overgrowth, plus low FODMAP, which will satisfy for bacterial overgrowth. And case in point on this, a 2021 randomized control trial gave patients with GERD a low FODMAP diet for 1 month, and they saw a 38% improvement in that 1 month. So 38% I would say is pretty good, but I'm looking for 90 to 100%, which is why this needs to be a multiple component intervention, right? So paleo low FODMAP, great place to start. And we're going to layer on top of that, or along with that, some anti-inflammatories. Curcumin, like we mentioned before, as that one study found, 2 grams per day, which is a pretty standard dose. And you can also consider adding melatonin, which a 2010 clinical trial found that melatonin, when compared to, again, omeprazole, and the melatonin was 3 milligrams at bedtime because it can help with sleep, so we don't want to take it during the day. Now, both groups had improvements in heartburn and some of the pain that is associated with GERD, but only, key point here, the melatonin group had improvements in lower esophageal tone. So more and more data showing us that there's a better path than omeprazole. Pairing curcumin and melatonin seems to make a lot of sense because it's going to have multiple benefits. By the way, melatonin is also a fairly powerful antioxidant. So the curcumin can help with reflux and with things like joint pain. The melatonin can improve sleep. It's an antioxidant and will also improve lower esophageal sphincter tone. And I would combine that also with some formula that's aimed at repairing the lining of the gut. The one that we've developed and I'm very proud of because the flavor profile and the efficacy is quite good is Gut Rebuild Nutrients. There's a number of ingredients here: vitamin A, zinc, glutamine, N-acetylglucosamine, DGL, aloe vera. DGL, as one example in a recent clinical trial, was found to be more effective than antacids yet again. So curcumin, melatonin, and Gut Rebuild Nutrients. Remembering these will not need to be used forever, but coming back to that back injury rehab analogy, for a few months. Like I said, phase 1 to 2 months, then reevaluate. Very importantly, a good probiotic. Probiotics have been shown to improve GERD, to reduce inflammation, to reduce leaky gut, to combat SIBO, H. pylori, and fungus, and also lower levels of histamine. Looking at a 2020 systematic review, 79% of the studies reviewed found that probiotics improved GERD. Quoting, in conclusion, probiotic use can be beneficial for GERD symptoms such as regurgitation and heartburn. What you see in the research here is most of the studies have examined the type of probiotic we call a blend of lactobacillus and bifidobacterium. This is kind of your traditional probiotic. For this type of probiotic, and on the label, you're going to be looking for predominantly lactobacillus and bifidobacterium, anywhere between usually 8 to 15 different species, at a dose of 1 to 50 billion per day. A little higher is fine, but that's the general dose range, for about 2 months. Now, to have the strongest probiotic, our hypothesis is you want to combine the 3 formula types together so as to have, we call it the triple therapy probiotic. So you combine this with Saccharomyces either Boulardii or Cerevisiae, and you'll see the dosing here listed, but essentially 10 to 15 billion or 4 to 8 billion for 2 to 3 months. And then finally, a soil-based probiotic. This will have various bacillus species in the formula at a dose of 2 to 6 billion, again for 2, maybe 3 months. These 3 different types have all been studied and documented to be beneficial for GERD. So again, my recommendation, so as to get the most out of the probiotic protocol, would be combine all 3 together. If you're trying to be minimalistic, you could use just one of these formulas. And if you're not sure which one to start with, I would simply start with the lactobacillus and bifidobacterium blend. Okay, so we talked about the nervous system, sympathetic, parasympathetic, vagus nerve, acetylcholine, anti-inflammatory, and also promotility. What can we do? There's some really obvious things. Meditation, mindful eating, meaning you're not eating in the car, you're not eating while watching TV, you're eating while slowing down, chilling out, relaxing. And then, as it's called, Shinrin Yoku, or just time in nature, very strong parasympathetic. And then for the physical factors, diaphragmatic breathing. This is just slow, deep breaths into your belly. There was a 2020 meta-analysis of clinical trials, so this is the gold standard data point, that found diaphragmatic breathing can actually enhance what's known as crural tension. So there's this section of the diaphragm that sits sort of alongside the lower esophageal sphincter. And diaphragmatic or deep belly breathing will strengthen these muscles that help to hold the lower esophageal sphincter in place. Quoting this meta-analysis, breathing exercises can enhance the crural diaphragm tension, or CDT, strengthen the diaphragm barrier mechanism, reduce acid reflux and subsequent damage, and improve the efficacy of drug therapy. How do you do this? Inhale deeply through your nose, let your belly expand, and exhale slowly through your mouth. Do this ideally 15 to 30 minutes per day. If you can't do it for that long, do the best you can for 4 to 7 days per week. A few other physical factors. Remember, don't slump or slouch after eating. Don't lay down after having a meal. So therefore, I would avoid eating 3 hours prior to bed. And to whatever degree you're able to get to a more normal weight, I would do so. So those are the factors for the month 1 protocol. You don't necessarily have to do all of those. The more you do, probably the better your results will be. But take stock of where you think you need more intervention. Let's say you're already eating low carb, then maybe pivoting to inclusion of low FODMAP makes more sense for you. Let's say you're already doing a lot of relaxation, then maybe you don't need deep breathing. Or conversely, if you're under a lot of stress, then maybe that's something more important to include. We'll also give you a simple way of stimulating that vagus nerve in a second. But that's your month 1 to 2 protocol. And again, if that's the right series of changes, you'll see improvements. Now, it's possible that some people will see only partial improvement. I would be shocked if someone did not see any improvement from these changes. But more likely, there will be a 30, 50, 60% improvement, and then you plateau. This is where the second phase for another 1 to 2 months comes in. There's a dietary nuance that you can try called a low histamine diet. Histamines are signaling molecules of the immune system, which can be inflammatory. So if you currently have a high level of inflammation in your system, then consumption of a high dietary intake of histamine can actually make you more inflamed and can flare reflux. So again, a 1 to 2 month rehab plan, if you will, of avoidance can be helpful. Here are some of the most commonly consumed high histamine foods that you want to therefore avoid. Fermented foods, and these are, I think, very healthy and very good to include in your diet, fermented foods, but for some people, short-term rehab can be helpful or avoidance. So this would be your sauerkraut, your kimchi, your kombuchas. Additionally, aged cheeses, cured meats like jerkies, fish and seafood, even though can be very healthy. Again, short-term corrective avoidance. Alcohol, probably not going to help anything. Vinegar and other vinegar-rich foods. Certain vegetables, tomatoes and spinach. This is not an exhaustive list, but it's just giving you some of the more common ones. Fruits, avocado, citrus, strawberry, and banana. Soy products. And finally, leftovers. Anything that's been over 24 hours is probably accruing a decent amount of histamine, so do your best to avoid leftovers past roughly the 24-hour mark. Now, very importantly, what might be holding some people back from getting past that 30, 50, 60% improvement could be a more stubborn imbalance in the microbiome. And this is where herbal antimicrobials can be very helpful. I'll put up here on this screen, quickly the herbal antimicrobial protocol that we recommend. There are 4 agents. 2 are used for the first month. 2 different ones are used for the second month. They're a mixture of various antimicrobials that are anti-inflammatory, antibacterial, so therefore we'll address SIBO, and antifungal. Blends seem to be better than just one ingredient, which is why we have 2 blends that then rotate into 2 different blends the second month. And this is detailed in much more detail in Healthy Gut, Healthy You, but you have the protocol quickly here. And then if you wanted to go much deeper, I would refer you to Healthy Gut, Healthy You. And I did want to quickly turn things over to Dr. Scott for a case study in the clinic that exemplifies how important antimicrobial therapy can be.
Hey, this is Dr. Scott from the clinic, and I just wanted to quickly share a case from our office that highlights a few of the points Dr. Ruscio has made in this video. Jenny came to the clinic with her main symptoms of severe acid reflux and bloating and belching. She had been previously tested for SIBO and H. pylori, both of which were negative in her case. And she also previously tried a low acid diet and a low FODMAP diet, both of which were partially helpful, but they didn't fully resolve her symptoms. What's interesting in her case is that her symptoms began a couple weeks after she had taken steroid medications and antibiotics, which we know are common risk factors for the development of fungal overgrowth in the digestive tract. So in her case, I highly suspected a fungal gut type as the primary driver of her bloating, belching, and reflux. So she was put on a low carbohydrate diet and herbal antimicrobial, so BiotiClear 1A and BiotiClear 1B. And 2 months later of that protocol, she reported that her reflux, her constant burping, and bloating were nearly resolved.
So a good example of how fungal overgrowth, even when someone's done some of the other work for reflux, can be the missing link in some people. And again, that's what we have covered in our plan here. There is a vitamin deficiency that may also be implicated in non-responsive reflux, GERD, LPR. And this is vitamin B1, thiamine. Vitamin B1 is actually needed to make that acetylcholine that the vagus nerve produces. Deficiencies can interfere with motility, can interfere with lower esophageal tone. This is not something that's been researched in the application of reflux specifically, but there's been enough clinical observations to where I think this is something that you could consider a 1-month protocol on a vitamin B1 supplement and see how you do. And regarding a protocol for thiamine, what I'd recommend is a product developed by Elliot Overton called Thiamega, dosing at 1 and then working up to 4 capsules per day as a general starting point. This will give you, roughly speaking, 100 to up to 400 milligrams of thiamine per day. This supplement does contain different forms of thiamine. We also did a much more comprehensive conversation, protocol review with Overton on this, and I'll refer you to that here if you wanted to go deeper. That being said, I do think that the thiamine protocol previously was unnecessarily complicated, which is why I really appreciate this combination product and a more simplified protocol. The way I look at this is if someone has a deficiency in thiamine, it is important to rectify it. And I don't think it's going to be highly dependent upon having the absolute crucial balance of one form versus another. In fact, most of the interventional trials that have repleted people with deficient thiamine have used one form or the other form or the third. There's really about four forms. But the point I'm making is they've used one of the four and seen good results. So I like the idea of a combination all in one to make it easy. And I'm not totally sold that the previous protocol we had discussed that was much more nuanced is necessary. Thiamine B1 deficiency can cause problems with motility, including upper GI esophageal motility and the vagus nerve, everything else we talked about. It is an important thing to think about if you're having non-responsive reflux. And also, historically, if you've consumed a high carbohydrate diet, especially things like white rice, white breads, then this increases the likelihood that you are thiamine or B1 deficient. So there is your simple protocol starting point for repletion. Vagal nerve stimulation. So we talked about, again, sympathetic, parasympathetic, rest and digest, governed by the vagus nerve regulating motility, acetylcholine, and being anti-inflammatory. So for some people, they may have stressors in their life that are not modifiable. Let's say you have little children who aren't sleeping well, or there's work stress or academic stress that you can't get around that. And you may not have the time to do the time in nature, or you're limited to how much you can do and you're already doing it. So what else could we offer you? This is where I am very excited about vagal nerve stimulation. A 2024 study took 44 patients with silent reflux. They had them undergo vagal nerve stimulation, and I'll give you the details on what that is in just 1 second, for 30 minutes a day, 2 times per day. They saw a 64% decrease in reflux symptoms, improved upper and lower esophageal sphincter tone, improved anxiety and depression, and also improved tone or output of the vagus nerve. This is why I'm so excited about these devices. This can be as simple as wearing a pair of headphones that create a slight buzzing sensation. It's known as auricular vagal stimulation. And the ear, or the auricular stimulation, will hit the tragus nerve that's going to travel upward and regulate the limbic center of your brain, which governs your fear and emotion response, hence the reduced anxiety and depression, but also travel downward and have an immediate parasympathetic effect in the periphery. So you could be going through your morning routine and brushing your teeth, doing dishes, whatever it is, same thing in the evening, and just simply wearing these headphones and getting a similar effect as doing 30 minutes of diaphragmatic breathing or meditation or what have you. So for some people, I think this is a real win. And we've been using these in the clinic now just for a couple months, but already we're seeing people say, I'm sleeping better, I'm less anxious, my bowels have improved. So I think it's a really nifty therapy. The device we've been recommending is VaguStim, and you can order it online fairly easily. Now, if you have been diagnosed with a hiatal hernia, there are adjustment techniques that a osteopath, a chiropractor, or a PT can perform to try to manually reset that hiatal hernia. So that's something potentially to look into. And then the very last thing to consider, coming back to Mason's case, would be support for low acid. There's 2 options you have here. Digestive bitter, so these are various herbs like gentian, dandelion, artichoke, sometimes orange peel. These help to stimulate your natural secretions of acid and also motility. I think those are a great option to start with and try. There's also actually taking acid as betaine HCl or hydrochloric acid, and this is what Mason did. And I would recommend dosing only 1 to 4 capsules per meal. And again, if this is the right acid supplementation in particular, support for you, you will know within a few days to a week. So do not prolongate the experiment devoid of any positive response. So in close, we've covered the 6 causes. We've touched on 3 cases that illustrate the success one can experience. By the way, Mona's case was mainly bacterial overgrowth. I didn't mention that before. So Mona's case was bacterial overgrowth. Mason's case was dysbiosis and also low stomach acid. And then Dr. Scott's case was fungal overgrowth. Take this one step at a time. And remember, if the changes are the right ones for your system, your body will let you know within a couple weeks, certainly within a month. And if not, keep working the problem. You have a lot of homework here. And if you get stuck, feel free to reach out to our clinic anytime. We are more than happy to help. Alrighty, well, let me know what you think in the comments. Pose any questions there. This is Dr. Ruscio. I hope this helps, and I'll talk to you next time.